everyone. Today we'll revise general surgery, gastrointestinal topic, and we can do it very fast, only the important points about the important topics. So we can start with the upper GI. First of all, we can start with esophagus, and then we have gastric. So let's start with esophagus. So esophagus will not go detail into normal physiology. I'll cover it up in different videos where I'll share more pathophysiology. So first of all, we'll study about GERD. So what is GERD? Gastroesophageal reflux disease, and it produces like vague symptoms of epigastric distress, and mainly in overweight patients, and they complain of retrosternal pain or heartburn, and that heartburn and pain gets aggravated while lying flat or wearing tight clothes or bending over, and they try antacids, but they give initial relief, but soon they don't relieve the symptom in long run. So they also use H2 blockers over the counter. So to diagnose it, what we have to do, we have to see the pH monitoring to diagnose the reflux and to correlate with the symptoms. And if there is very long history of the reflux and we are concerned that there is a damage that could have been done to the lower esophagus due to constant acid attack on it, and also the risk of Barrett esophagus where there is metaplasia from columnar to squamous change. So in that case we can go for endoscopy and biopsy. Otherwise we can do 24-hour pH monitoring. And treatment is H2 blockers, proton pump inhibitors, lifestyle modification. So lifestyle modification is to improve your diet, to stop smoking, and to avoid more coffee and chocolate. These things, they cause laxing of the lower esophageal sphincter and cause the reflux symptoms because the sphincter is not able to tighten the opening and the acid reflux back. Surgery is required in the case where none of these medicine is working. And what kind of surgery is required? We say Nissen's fundoplication. From name itself, fundoplication. So in this, what we do, in this we first of all, it is done laparoscopically, and it is done when there is refractory medical management and other medicine the patient is not able to tolerate, and there are some local complications that are occurring like ulceration or stenosis. So we plicate 360-degree Nissen's plication, and we tighten the opening so that it doesn't regurgitate back. So we'll not go into detail of that. So what is the motility issue that can occur? Like there is crushing pain with the swelling, swallowing any solids, and if we do the barium swallow, we'll see if there is any obstructing lesion. Otherwise we'll go for the manometer that we have discussed before also. So now we'll come to the other disease, which is eclasia cardia. It is more common in females. And what is this? This is like physiological obstruction. Normal there is physiological obstruction, and in this case the obstruction causes it difficult to swallow liquids as well as the food, and the food is regurgitated sometimes, and the patient tries to sit straight and it he waits for the column of liquid to pass through the sphincter and then goes for the another bite. And so in this case, what we can do, we have a rat tail appearance here at the end because there is constriction of the esophagus here, so there is not passage of food properly. And what we're gonna do, we're gonna again give the barium esophagogram we can do. And then if we can see the rat tail appearance in this. And if it's not diagnostic, then we can go for the endoscopy and see if there is cancer or any mass that is obstructing the lumen. And we can also go for the x-ray, and in x-ray we'll see the esophagus distal to proximal to the constriction. It will be dilated, okay, because food is not able to pass down. So we'll see a big esophagus. Now what will do the treatment? The treatment is simple. We'll pass an endoscope, we'll pass a dilator through it, we'll dilate the constriction, and we'll give Botox injection to the lower esophageal sphincter. And if the recurrence is very high and it's not responding to both of them, you have to give multiple times, then we can go for Heller myomyotomy, and this is only in the case of recurrence. And now the other important thing that can be implicated in the esophageal disease are cancer of esophagus that can occur, that can also cause the obstruction. And it starts with the solid, and then it starts with the soft foods. The patient is having difficulty to swallow them, and the main is what we see cachexic effect of a cancer, weight loss. And it can be two types. It can be squamous cell carcinoma, it can be adenocarcinoma. Now squamous is more common in people who are smoking and who are drinking, and adenocarcinoma is more prone to people who have long-standing GERD, because we know the long-standing GERD lead to the Barrett's esophagus, and Barrett esophagus is a metaplastic change, and post that occurs dysplasia and then the full-fledged cancer. So what we can do it, again we always start with a barium esophagogram, and then we're gonna go for an endoscopy. Via endoscopy we can take a tissue for the biopsy. Also we can use endoscopic ultrasound, CT and PET to assess any local and lymph node involvement, and we have to stage the cancer with them. Now if there is an early stage lesion, we can go for chemo, radiation and surgical resection of the mass. And if it is a late stage, mainly the modality we use is chemotherapy, and prognosis for esophageal cancer is very poor. Now we come to the another pathology, that is Mallory-Weiss syndrome or Mallory-Weiss tear that occurs. This occurs due to any forceful vomiting. Patient is trying to vomit and it is forceful and prolonged, and that leads to the mucosal tear, and this mucosal tear leads to the bleeding. And this mucosal tear mainly occurs at the gastroesophageal junction, and it leads to the hematemesis. Hematemesis is what there is in emesis, there is blood. Blood, emesis, your vomitus, and then there is blood in it. So that we can go with the name itself. And with endoscopy we can see it, and we'll see the tear here. And what we can do for treatment, we can endoscopically clip it, or we can coagulate any opened bleeding vessels. So other thing that we confuse Mallory tear is with Boerhaave syndrome. Now Boerhaave syndrome is rupture of the distal esophagus due to prolonged forceful vomiting. See, that Mallory-Weiss was just a mucosal tear, a laceration that lead to hematemesis and can be controlled easily, compared to the Boerhaave, which is rupture or perforation of the distal esophagus, and it is sudden in onset, and it is due to continuous and severe retching episodes, and there is epigastric pain, and there is epigastric pain, and the patient is having fever, leukocytosis, and very sick looking patient. And so what will treat the patient, how will diagnose it? We'll use a water soluble contrast. Water soluble contrast in esophagogram is diagnostic. This is just using water soluble contrast instead of barium, so that there is minimum damage due to the contrast material, and we can recognize it, and we can manage it endoscopically by placing any stent, esophageal stent, and we have to keep the patient NPO, and we have to give the nutrition with distal enteral feeding, with like percutaneous endoscopic gastrostomy or jejunostomy. We prefer it over the total parenteral nutrition, because that we'll see in future videos. Total parenteral nutrition has its own side effects, so it's better we go with the enteral feeding. Now this was a Boerhaave, and other is very specific perforation, which is due to instrument. When you are doing any endoscopic procedure, then you can damage the mucosa of esophagus with your instrument. See, that can occur. That means it's iatrogenic, and there is a pain, post procedure pain, and we can see emphysema in the lower neck, which is a kind of diagnostic for this. And we have to diagnose again with the esophagogram, and treatment is we have to do prompt surgical repair, and because we'll just explore the neck, and we'll see for the tear wherever it is, and we'll surgically repair it. So that is very important. So this was about a very short video about esophagus, just to see your feedback if you like. It's just for remembering small topics very fast. So let's see gastric surgery and intestinal surgery topics along with other important surgeries in the next video. Thank you.